Good morning, America. Good afternoon, Europe and Africa. And good evening, Asia and Australasia. Welcome back to the ISRRT Facebook Live. And today we have a very special program in collaboration with International Society of Radiology, ISR Quality and Safety Alliance. The topic for today will be about patient shielding, what is happening around the world. And we have a list of experts from all around the world to talk about this, both radiologists and the radiographer. First of all, I would like to invite our president, Donna Newman, to have the opening speech. Donna.
Thank you, Napa. Good morning, good afternoon, and good evening, everybody. I am so excited today to have these experts from around the world. We have some of the key leading expert radiographers and radiologic technologists today here to share with us about shielding aspects within their countries. And I want the world to know that the ISRRT supports and endorses their member society's stance on patient gonadal shielding. We believe that these key experts from around the world can help give some best practices relating to this issue. And we hope to have some good conversation during the panel discussion. For all of those around the world that are looking for information on it, please go to our website, the ISRRT position statement, and the websites of our experts from around the world that have some great information on the shielding aspect. So I look forward to our conversation and learning from our experts. Thank you. And Dr. Fresh, I now turn it over to you as our co-host for this session.
Well, thank you, Donna, and welcome to everyone who could join today. As you all know, the mission of the International Society of Radiology is to facilitate the global efforts of the member organizations and really those populations that they work together with and the patients they care for to improve patient care. And I can really think of no better topic that embodies that mission statement than this topic of gonadal shielding. I'm looking forward to hearing what other individuals have to say, the panelist discussion today, and on behalf of the ISR leadership, so pleased to be with the ISRRT and this opportunity to talk about this most important topic.
Thank you, Dr. Fresh. And now I would like to introduce the four speakers that we have for today. I will introduce you all at once. The first speaker, Professor Mark McEntee. He is the professor and chair of diagnostic radiography at University College Cork from Ireland. And we have Professor Donald Fresh, who is the professor at Duke University Medical Center from the United States of America. And Professor Fresh is co-chair of International Society of Radiology, ISR Quality and Safety Alliance. The third speaker came from Hong Kong, my very good friend, Edward Chan. He is the vice president of Hong Kong College of Radiographers and Radiation Therapists from Hong Kong. And last but not least, we have our colleague from United States, Daniel N. Demiel. He is the American Society of Radiologic Technologists, ASRT, Speaker of the House. So we have four experts, including radiographer and radiologist, who will give you what's happening in terms of patient shielding in their practice, both in their country and their organization. Now, I would like to start with Professor Mark McEntee.
Good afternoon, everyone, and thank you for the invitation from the ISRRT to present today on shielding practices. I'm going to present two talks today on shielding practices, one that focuses on Europe in general and one that looks at the UK and Ireland. And hopefully this will be of interest to the community listening. My name is Mark McEntee and I'm Professor of Radiography at University College Cork, shown here on the screen. University College Cork is nearly 200-year-old institution with a great history of research. I'm also an honorary professor in the University of South Denmark. And I'd like to thank my collaborators on this work, Dr. Andrew England, and also our MSc students who graduated recently, Ms. Maeva Hearn, Mr. Mark Calotti, and also Ms. Grania Curran, who was a supervisor on some of this work. So it's really important to understand that radiographers' attitudes to shielding will change depending on what's going on in the community and depending on guidance. So we did a study in 2020, shortly after the publication of a statement and the guidance from the British Institute of Radiology. And that guidance was called Guidance on Using Shielding in Patients for Diagnostic Radiology Applications. And after the publication of that, we carried out a survey via the EFRS Research Hub. And this takes place in the European Congress of Radiology. And we had 114 radiographers took part in that survey. Later on, there was the publication of the European Consensus Statement on Patient Contact Shielding. And again, in 2002, we carried out a survey of radiographers in the UK and Ireland, and we had 112 participants today. So in today's presentation, you'll be seeing the 2 time points after the publication of 2 important documents. So let's start with study 1. This was the BIR statement on the use of shielding in patients in diagnostic radiology. And we surveyed after the publication of this of European radiographers, and they answered the questionnaire at the European Society of Radiology meeting at the Research Hub in 2021. So the age categories ranged from 25, with over 42 being the most common age category of respondent. We asked them to start off, if you were being x-rayed yourself, would you request lead shielding? And we can see that 14% of the radiographers in this study said yes to that, and 34 said it would depend. So, and 50% said no. So 50-50 really, 50 said maybe, and 50 said no. So that'll just give you a sense of where the radiographers were starting off with this, thinking of themselves. And so in the first part of this, I'm going to report the results about their beliefs. So they believed that, in your opinion, when the patient is exposed to radiation, what would you consider the patient is most worried about? 68%, 70% of the radiographers said that the patients are most worried about cancer, followed by the risk to the gonads, and then very small for hereditary. Do you believe that the application of patient contact shielding is an effective method of protection? 44.7%, so for around 45% said no. And 50%, over 50%, the remainder said either yes or undecided. So they over 50% either believe that shielding is an effective method of protection or they're undecided. An important note on that slide is to say that it's not as clear as some people would like you to believe that the consensus is that shielding is not needed. Among radiographers, over half of them either think that shielding is useful or they're not decided yet. Do you believe that lead protection should differ for children? 50% said yes, 15% said they don't know, and 34% said, no, I think everybody should be treated the same. We asked them, do you think contact shielding in the primary beam should be used for females on a regular basis? Only 7% said yes to that, which is good. This wouldn't be recommended. Shielding inside the primary beam has risks. Do you believe that lead protection should not be used for pregnant? So this is a question, should not be used for pregnant women for examinations outside the pelvic region. 37% said yes, it should not be used. And 41%, the majority, said, no, I think lead should still be used outside the pelvic region for pregnant women. We asked them, do you believe that lead protection is a manual handling risk? Now, the reason why we asked this is because that was one of the rationales given in the British Institute of Radiology guidelines. Almost everybody agreed that it was no risk, low risk, or so we had 85% of people said it was no risk or low risk. And I think radiographers would generally agree that that is not something they worry about when they're using manual handling, when they're using lead aprons. Then we moved on to questions about their practice. So we finished with the belief section now, and we're talking about their actual practice. So we asked them, do you use contact shielding outside of the primary beam on a regular basis? 17% said yes. 36% said it's situation dependent, and 46% said no, they don't. So again, here we have this 50-50 split where we have half of the group almost saying no and half the group saying yes sometimes. We asked them, for which practices would you regularly use contact shielding? And we can see the majority of people responded to none of the above. But we have 23% said chest, 24% said pelvis, 16% said spine. How often do you ask ask as a radiographer? Sorry, how often do patients ask you about lead protection? The majority here said rarely. 56, almost 60% are rarely asked, and never, it was 11%. So patients do ask about lead protection. Only a very few of radiographers said that they're never asked. Do you take time to explain to patients about the rationale for lead protection? The majority, 73%, said yes, they do take time to explain the rationale for protection. Do you explain the risks and benefits of the patients for the use or the non-use of lead shielding? 34% said yes, 41% said sometimes, and the minority, 24%, said no. So almost 75% of the time, radiographers will explain the risk benefits. It depends on the situation. Would you apply shielding as a means of reassurance to the patient? And this was interesting, again, a similar split to before. 30% of radiographers said yes, they would. 50% of radiographers said yes, but it's situation depending. So we have 80% of radiographers there who said yes, they would, or yes, they would, depending on the situation. Only 15% of radiographers said no. And we asked them about the, obviously it was relevant at the time, the COVID pandemic. We said, has this changed your practice of using lead shielding? And 60% of radiographers said yes, the COVID pandemic did change their practice. And this was related to reducing their contact or removing their contact with patients. When it came to protocols, so this word protocol tends to mean the local guidance or the local rules about shielding in the department. We asked them, is there a protocol in your department for the use of shielding? And here again, we see that sort of 50-50 split, 50% saying yes and 50% saying no. Do you think that it would be beneficial to have protocols in your department? Again, a massive majority, almost 80% said yes, it would be helpful. And 7% said no, and 13% said maybe. We asked them about education. We said, do you think students should continue to be taught about the use of lead protection for every examination? The majority said no, that teaching needs to change. And so it needs to be changed to dependent on the situation. We asked them, do you agree with the BIR statement that contact shielding should not be used during fluoroscopy? And 80% agreed yes. We asked them, do you agree with the BIR statement that contact shielding should not be used during any procedure in CT? 60% said yes here, but a significant minority were unsure. We asked them, do you agree with the statement that radiation protection shielding should be routinely applied to patients undergoing mammographic, that no shielding should be used undergoing mammographic procedures? 80% said yes, and 20% said no, they don't agree with that. You would use lead protection during mammography. And we asked them, do you think it will be difficult to implement this research? And interestingly, we had 50% said no, it won't be difficult, whereas the other 50% said either yes, it will be difficult, or they're not sure. And we asked them why they think it might be difficult, and 50% said radiographers will be reluctant to adopt the guidance, and whereas 27% said patients will insist on lead protection. So that was an overview of study 1. Again, that was carried out after the production of the BIR guidance. Study 2 then was carried out after the publication of the European Consensus Statement on Contact Shielding. And this was carried out of radiographers in the UK and Ireland, and we had 112 participants in this survey. So the survey was mixed methods. It had a combination of tick box answers and areas for the respondents to fill in. Section A had 17 questions about the radiographer's awareness of the consensus statement. Section B had clinical scenarios. We asked them about when they would and wouldn't use shielding. Section C had a qualitative questions on radiographers' opinions regarding the statement. And so our results, about 50-50 in terms of who had read the statement. So 55% said no, 45% said yes, they had read the shielding. We asked them again about the manual handling risk. And again, this is UK and Ireland respondents. 54% disagreed that lead was a manual handling risk, and 18% strongly disagreed. So sorry, my mistake there. We had 54% disagreed and 18% strongly disagreed. So about 75% of the participants disagreed that it was a manual handling risk. And does dose get saved by shielding outside the field of view? Is the doses saved negligible? 53% said that it was negligible, and the remainder either they agreed strongly. 75% strongly agreed or agreed that it was negligible, and the remaining 25% either were neutral or disagreed. So, does lead cause patient discomfort? The majority disagreed with this, so either strongly disagree or disagreed with it. The remainder were neutral, and some 25% agreed, and 5% strongly agreed that it causes patient discomfort. Is the statement best practice? So this was, is the consensus statement best practice? There was about 60% of respondents either agreed or strongly agreed that it was best practice. 30% were neutral, and 6% disagreed and with that statement, and 2% strongly disagreed. So this is the consensus statement. Is it too restrictive? And the question here is, does it remove the ability of the radiographer to make decisions? We had 16% agreed that it was too restrictive, 3% strongly agreed. The majority, 51% were neutral, and 25% thought that it wasn't too restrictive, and 3% really strongly thought that it wasn't too restrictive. So we begin to see this pattern emerging across both studies where we have this sort of 50-50 split. So we gave them clinical scenarios. So we gave them a specific patient where we said that a bariatric patient for a pelvis x-ray, indicating that the patient was large and we were doing a pelvis x-ray. We asked them, do they use a lead shield at all? Now, this is where we got some of our clearest results. When we give specific context-based scenarios, then we get the best answers. Effectively, people here are 90% of patients saying, of respondents saying they don't use shielding in this scenario where the patient was large and you were doing a pelvic X-ray. If the female bariatric patient with previous mastectomy and BRCA mutation, so we're trying to indicate here this is a high-risk patient, again, the same, 86% of respondents said they wouldn't use lead shielding, even though this patient was high risk of developing a cancer. When we said an 11-year-old female arrives for a pelvic X-ray, again, 82% of patients says they don't use lead shielding at all. So this results in a discussion in which we see that there is increasing evidence for the impact of low dose radiation on patients who are high risk, but also at the same time we see that there are studies that indicate that radiographers have this dichotomous practice. So this is a study published by Hare et al. Back in 2017, and they reported radiographers may not utilize lead in all situations. It's dichotomous, and it depends on the practice. And pregnant patients are one of the examples that they pointed out where radiographers would or would not use lead shielding, and it's dichotomous. But this is in the background of increasing evidence that low dose radiation can be a risk to certain populations. And that there is epidemiological evidence for low dose ionizing radiation in cancer, and there's a meta-analysis done of this that demonstrates that there is a relationship between low dose and development of cancer. So in our discussion, finally, we asked the questions of radiographers after two important publications were produced. And in the context of all of these things, radiographers tend to indicate that it's about 50-50. The majority of radiographers, generally 50%, are not using lead. The other half are either they use it in some scenarios or they use it all of the time. And when you ask them about specific scenarios, then you get your clearest answer. So if you want to know about practice, you need to ask about specific scenarios. And we find that in those specific scenarios, a lot of radiographers are not using lead. So there's broad awareness of the European consensus statement. There's no uniform agreement with its recommendations. There's disagreement regarding some of the statements, particularly on the effect of the dose. Particularly on the availability and the use of shielding. The radiographers would indicate 50% of them would like to have the option to use it in certain circumstances. They disagree that it causes any patient discomfort. They disagree that it's a manual handling issue. And although contact shielding is not commonly used in radiography, a large number of radiographers still use it. And the consensus statement has been widely misunderstood as banning shielding when it doesn't do so. It specifically says that it can be used in certain circumstances. And another thing is that the effects of low-dose radiation are not fully understood. Future work by our group, we're going to do patient focus groups to ask patients what they think about this area and see is it important to them. And we're going to look at the use of in-plane and out-of-plane shielding in various scenarios and do more testing with digital systems and using digital dosimetry. So thank you very much for listening. I hope this was of interest to you, and I look forward to meeting you in person in the future. All the best.
My name is Don Frush, and I am a pediatric radiologist at Duke Medical Center, and it is a real honor to be involved with this group as we discuss global perspectives on the change in practice of patient shielding. I will talk about three different issues here. First, discuss a little bit about the background for this change in practice, some of which may be redundant, but I think it's important to emphasize these issues with why we're doing things differently. I'll also discuss briefly the role of the radiologist in terms of being supportive of embracing the changes in practice of gonadal shielding, and finally to understand the current regulations and guidance and some of the implications of these in the change in routine shielding in the United States. First, it's important to remember that we still do a lot of radiography. It's fully 86% of those ionizing imaging modalities that we do. And if you take all imaging modalities, including ultrasound and MR, fully 2/3 of those imaging modalities are radiography. Now, I think you have seen or will see in these talks that shieldings can be misplaced. In this case, the testes were not covered, maybe high riding or retractile. In this case, probably over-shielded and incompletely providing diagnostic information. In this case, probably under-shielding. And I want to emphasize that this misplacement of shields is not being judgmental. In fact, many of the shields, when they're placed according to standard guidelines, may be ineffective in shielding the gonads. And here's another example where actually pathology was obscured by the shield. This is infection, osteomyelitis in the right pubic symphysis, something very important to determine in terms of diagnostic radiography. Now, I thought it was interesting to provide a little historical perspective here. And these were some of the gonadal shielding devices back from the 1950s, et cetera, and a little bit medieval in appearance. And I also put this article into because this was an excellent review within the past couple of years. And I put some additional references at the end of this talk that I'll go through where you can revisit much of this information here. Now, in 1950s, there was widespread practice of radioprotective lead shielding. In 1976, the U.S. FDA, in its federal registry, had recommendations for the placement of gonadal shields. It should be used to protect the gonads from radiation exposure that may have genetic effects. And remember, the reason for the placement of the shields was predominantly for genetic effects. And I'll talk about what the evidence now states and why this isn't as supported. The current U.S. state regulations do vary state to state, but the vast majority are fully or wholly or fundamentally derived from the 1976 recommendations. And here I just put the federal registry up here where the shielding was discussed here. Now, information from the 1950s said that shielding reduces gonadal doses. This would have clear genetic benefits and so on. And that's not the correct information here. What we know from current scientific data is we do things much better now. So about a 95% reduction in both adults and children here with respect to technical advances in the equipment, the detectors, and the output for our radiography. What are all the what comprises the current evidence for change in shielding? And again, we have dose reduction. Gonads are not as radiosensitive as first thought. The ideal shielding is seldom achieved even when following standard guidelines here. It can be difficult when children are moving. With automatic exposure control, the detectors may be fully or partially covered by the shield, and the exposure then would increase. And this may be due to radiosensitive organs that are actually more sensitive than the gonads and result in higher doses to those organs. Much of the dose to the ovaries is unaffected by the placement of shield, correct or incorrect, because it's largely by scatter, and it can obscure normal anatomy as well as pathology. In addition, hereditary effects from radiation have not been shown to be statistically significant in humans, contrary to what was believed in the 1950s. And there's always the issue of hygiene when using something, reusing something in medical practice. The major organizations involved in the early efforts dating back a few years ago now, about 3 years ago, are listed here. And I've provided two references here. These were some of the early documents which were partially responsible for activating this change in practice. Now, what is the role of the U.S. radiologists in practice change. And these are the things I believe that we should do as imaging experts. First of all, we need to have a responsibility in the design, implementation, and audit of shielding practice, be supportive of the technologists and radiographers, be advocates for their practice, serve as a necessary resource in case further discussions with patients or those that care for them are required. We need to engage the practitioners, those that order examinations, pediatricians, emergency medicine providers, et cetera, about this change in practice so they understand why this is done. And we need to function as informed sources, as advocates in regulatory and guidance manners. Now, what are the current regulations and guidance in the U.S., and especially what are the ramifications of this change in practice? First of all, I will say again that the radiographers and the technologists are the face of radiology practice, and we need to be supportive and engage with these individuals in terms of the change in practice for gonadal shielding. In 2019, the FDA revised its 1976 and is amending its regulations, although those have not been officially approved as of yet. And in 2015, the CRCPD also had a change in its requirement for the routine use of gonadal shielding. But still, the state regulations are fundamentally subscribing to the 1976 regulations by the FDA, and this change is happening slowly. The NCRP came out with recommendations in 2021 for the routine use of shielding during radiography, and I put both the recommendations listed here, as well as a document that had implementation guidance. That is, you can't just simply provide content of why this needs to happen, but it's how and how to be effective of that and be supportive of this. And this included information to the patient or the parent or the caregiver about why this change is happening. Now, the changes will impact, the regulatory and guidance changes are going to impact a number of different avenues. State regulations and legislation need to be changed. National agencies, ARRT and ACR, national and state societies, ISRRT, et cetera. The educational curricula will need to change. Accreditation for educational programs and credentialing for those involved in shielding. All of these things are downstream consequences of this change in practice. One of the enduring changes followed the NCRP recommendations in January. Just a few days later, the ASRT said that that routine shielding no longer needed to be continued here. So expectations and traditions are generations old. This will take time. Why didn't we do this before? Well, we collected data. There is new evidence about our current practice, et cetera. And it was really compiling all this information through the relevant professional societies that we decided it was time to change this practice here. Why do I need to wear an apron in my room, a radioprotective apron when my child doesn't? Again, this is in the United States, an occupational requirement, but we do need to have talking points for the technologists when this happens. My dentist still shields childs, or perhaps my chiropractor or another practitioner in town. And we do need to get consensus guidelines across all specialties using shielding. Certification, it's easy to be judgmental and blame. We need to not move along these lines. Radiologists have been relatively disconnected. And in fact, we need to be more engaged with the team that's obtaining radiographs and applying shielding here. When is diagnostic potential compromised? That shouldn't be a judgment of the technologist. And that, again, is one of the elements that adds to this change in not routinely applying shields here. Difficulties in the clinical environment. So I just put this up here because these were comments following a European Congress of Radiology presentation here, and I'll just list them here. But 21 of the 25 chat comments were critical of this change, and this is a global phenomena here, bordering on unethical, harms our patients, et cetera. So again, I just want to remind you that this is an emotional issue. This needs to be very carefully vetted. And how do we change this practice? And importantly, this is not a restriction, a prohibition. This is not, you cannot use shielding in any situation. There are situations where it may be helpful. For example, if it's remote from the exposure, or after a parental request, and there's an informed dialogue for the patient. But it must be resonant with the changes in the practice policy away from routine placement of shielding. So this effort needs to move away from routine shielding. The practice should then revise policy and guidelines to be current, include other medical specialties, as I said. And currently, the NCRP has another subcommittee out for comprehensive shielding recommendations. That is for all radiography, for all CT, for all ionizing radiation modalities, not just radiography of the abdomen and pelvis. Consistency is important. Talking points for radiographers and technologists are extremely helpful. And again, this is going to take time. And it's important to remember, do not overlook the fundamentals. For an enema, we don't need to get the pituitary gland in here. For an abdomen examination, we don't need to do a chabdomextremity examination where we have the upper extremities in the chest. So collimate, use appropriate immobilization, use only the appropriate views. These are fundamental and very important things. Here are some of the references here, and I'll just go through these. I've listed the websites here. AAPM has some good FAQs for technologists and patients, NCRP information here. Again, shielding modules through the AAPM. And I want to thank you for your attention to this. You all are such a have such a vital role in the performance of imaging, and I look forward to the discussions of my colleagues here. And this concludes my talk this afternoon.
Hi, everyone. Thanks, ISRRT, for inviting me to join this webinar. I'm Edward Chan, the Vice President of Hong Kong College of Radiographers and Radiation Therapists. This is my pleasure to present my experience of the patient shielding practice of radiography in Hong Kong and China. Okay, this is the outline of my presentation. I will talk about the radiation protection regulation of both places, Hong Kong and China. And finally, I will give a summary about the practice of both places. Okay, first of all, talk about the Hong Kong. Hong Kong is places have so-called one country, two system, even though we come back to the China now. In the Hong Kong, it's quite similar to the UK one. We have the Department of Health to monitoring all the medical practice. And under the Department of Health, we have the Radiation Board to manage the equipment licensing. The Radiographer Board is managing the licensing to the radiographers. And the radiographers, most of the radiographers come from the Polytechnic University and the Donghua College now. The biggest public sector employer in Hong Kong is the Hospital Authority, and the Hospital Authority will also manage the performance of the radiation protection of their radiographers. On the other hand, the professional organization, just like the Hong Kong Radiographer Association and also the Hong Kong College of Radiographer and Radiation Therapists, will give the up-to-date information for the radiographers to know the good practice in the radiation protection. If any problem happen about the radiation protection, the Radiation Health Division of the Department of Health, they will come in to do the investigation or maybe order the health institution to do the in-house investigation, also the in-house monitoring to give advice and try to improve in the future. Okay, let's see the document. In Hong Kong, we have the guidance note on the radiation protection for the diagnostic radiology. The most updated version is 2019 one. This document is taking reference from the ICRP, WHO, ILO, the International Labour Organization, also IAEA. In the document, we can see that they have specific chapter about talking about the shielding of organs. In the document, we can see that from the highlighted one, the document also asking our radiographers to do the proper corner shielding for the patient. because from their comments say, if we do the gonal shielding, we can help the male patient to reduce 95% of radiation dose. For the female, can reduce 50% of the radiation dose. So in Hong Kong, we still have this kind of equipment inside our examination room. There's the oval shape, gonal protection, even the T-shaped one. So we expect all the radiographer can produce this kind of proper image for the pelvic region. Okay, what's the challenging of the radiographers facing in Hong Kong? We know that we have a new hot debate about the gonal shielding. Just like the literature review in 2020, the researchers say, in the conclusion say that the gonal shielding seems to can be discontinuous. Because the contemporary radiography machine just produce very low dose to the patient. If we cannot give the proper gonal shielding, may induce the double dose to the patient instead of the without the gonal shielding. So without gonal shielding seems to be safer for the patient. And especially one of the very strong comment from the AAPM, they also emphasize that the gonal shielding seems to be no strong reason to use it anymore. So this is quite given quite impact to the practice to a certain extent. So we have considering about this new idea. But nowadays, because of the regulation and also our practice, I can say that most of the Hong Kong radiographers still applying gonal shielding. Of course, we will not cover the region of interest. We will not cover the detected area because we know that will increase the radiation dose to the patient. And most of our departments still believe the ALARA principle. Especially my colleagues from the Children's Hospital, they will insist to use the gonal shielding because kids are sensitive to the radiation. In some research, in other research, we can see that if we have good training, experience sharing, and the good equipment, we still can give the good gonal shielding. So we still see that gonal shielding should have some certain extent to keep it, to use it. How about the situation in China? In China, the radiology development is around the late 50 in the last century. The technology side development is around the late 70. They have the radiation protection regulation managed by the Department of Environment and Ministry of Health. I can say different because China is a big country. Different regions have their own Department of Environment and also Ministry of Health, just like the country, province, city, and district. And in China now, most of the radiographers are graduated from the university, and a little bit of them will still graduate from the technical school. After they're going to join the workforce, they will managed by their own health institution, just like the hospital or their clinic. In China, they also have their own professional organization to tell them the up-to-date information about the good practice of the radiation protection, just like the CSIT. If any problem happens, the government will send the inspector to the hospital to check the system. Sometimes they will check it periodically. And if the hospital want to develop some new service, they will also have to invite the third-party consultants to see the radiation protection is good or not. Okay, in China, we have several documents concerning about the patient shielding. Just like the picture I show here, at least we have. I have found 3 documents related to that. The left side one is a requirement of the radiological protection in diagnostic radiology, and the middle one is the radiological protection requirement for X-ray computer tomography. And the right side one is the radiological protection standard for the XME in medical X-ray diagnosis. You can see that most of the documents do not have long history, just quite short, just developed around in the 21st century. But most of the document were quite reasonable and professional. For example, they will talk about the justification. In the document, they will say what kind of exams should be using X-ray and what kind of patients should not use the X-ray. They also recommend the radiographer using the high kV, low MAS to reduce the radiation dose to the patient. they also mentioned about the good filtering, good condemnation are important factor to reduce the radiation dose. Of course, at the end, they will talk about the bonus shielding. Okay, let's see the patient shielding policy in China. In the poster on your left side, we can see that they have many protection device we have to use, and they have very, very serious protection to the patient. Just like this one, the patient going to a chest X-ray, we have to cover the bottom and also on the head. If the patient going to the chest fluoroscopy, the patient have to put on the cap, the thyroid shield, and also the lead apron to cover the bottom. The pelvis. For the CT exam, the patient have to put on the cap, thyroid shield, and also the lead blanket to cover the pelvic region for the patient doing the CT chest. So the dentist, the dental radiography is okay lah. It's okay for the using the head cap and also the thyroid shield. This is one recommend the patient, the companion person to use put on the protective gear. It's reasonable. But in Hong Kong, in China, we can see this kind of product in the market. So if any of you want to study about this protection device, you can contact me and I try to figure out how to get you one and for your study. It's quite interesting. Okay, now see I want to emphasize about the bonus shielding in CT because in Hong Kong, I do not do this. Even my colleagues will not do this for the CT patient. So when I come into China, I experience this kind of comment. So I asked my colleagues to do a research about how is it useful or not. In 2020, my colleagues published a paper, and in the conclusion of this study, say that using a lead cap, half lead apron, and the lead drip did not reduce the dose receiving in the head pelvis region during the CT chest scan. On the other, in another study, actually about 30 years ago, they also have a similar conclusion, say that the protection, the bonus shielding for the patient in the CT exam will not reduce so much radiation dose. On the other hand, we will reduce more scatter, more artifact for the CT image. Of course, in some study, we will have some the more positive comment about the bonus shielding. For example, another study in 2005, the researcher using this kind of a lead shield to cover the male scrotum for protect the gonad region. I don't know, is it feasible to use it when we so concerned about concerning about the infection control nowadays, and actually I don't think many male subjects willing to use this kind of cover. It's not easy to apply. So what do you think? Okay, now let's see the current situation in China. I can say that most of the patient shielding practices varies from different hospitals and different departments. It is because the workload and the funding system in China is very different from the outside world. The workload in China is very high because the funding system. The funding system is if the staff or the hospital or department do more patients, they can earn more, and the income of the staff will be more. So that's why the workload is very high, especially the population in China is very high also. But on the other hand, most of the department have their protection gear. They have full protection gear in the department. And the public, China public is want more protection when they do the medical exam. That's true. And when we go to have the government going to inspect the hospital, different inspector, they will have different interpretation of the regulation. So sometimes it's very difficult for us to manage the radiation protection policy in the hospital. No matter how, in my practice, in my hospital, we still believe the evidence-based practice. So we still ask our reviewers to do the proper gonad protection if they can. And actually, the new idea about the gonad shielding policy, I think it's quite welcome to the China's colleagues because their workload and their practice nowadays. Okay, well, this is my summary about what I see in Hong Kong and China. Most of us know the evidence have say that the gonad shielding is insignificant in the radiation protection. nowadays. And our profession should educate our public about this kind of a new concept about the radiation protection. But on the other hand, the radiographers should understand the concern of the patient. Just like if the patient very anxious about the radiation, we should give the radiation protection. And therefore, our radiographers should still keep the good technique of using the corner shield. This is my comment about our practice now. And when I want to make a picture to do my summary, I put all the keywords from my sentence to the Google search. Let's see what's coming out. This picture coming out from the Google search, EBP, this is an evidence-based practice. So no matter what's going on, the corner shielding or patient shielding, we still should follow the evidence-based practice, patient value, clinical experience, and scientific evidence. Thank you very much. This is my reference. I hope we have a good discussion afterward.
Hi, everyone. My name is Dan DeMeo. I am currently the Speaker of the House for the American Society of Radiologic Technologists. I'm in my 4th year of board service with the ASRT, and I'm absolutely thrilled to be here with you today to discuss our position on patient shielding. I want to begin by thanking the ISRRT, in particular your president, Donna Newman, for the invitation to chat with you all a bit today. Only have a few minutes to chat, so let's jump right in if you don't mind. Here's a brief outline of what I hope to discuss with you. We'll look at some of the recent historical perspectives on this change in patient shielding practice. We'll talk about the current ASRT position on it, and we'll also look to the future and talk a bit about a new initiative called the ASRT Patient Shielding Task Force. So let's get started. We'll start here with a brief history. Of course, it all dates back to about April 2019, when the American Association of Physicists in Medicine put forth their statement recommending the discontinued use of routine fetal and gonadal shielding for any diagnostic imaging procedure that involved the use of ionizing radiation. And again, that was now more than 3 years ago. Following that initial statement, we had multiple professional organizations endorse the statement throughout the summer of 2019 and really throughout the rest of the year. The ASRT did put forth an initial statement in July of 2019. We'll look at it in just a second. There continued to be more endorsements of the AAPM position here in the United States and across the globe throughout 2019 and 20. And then finally, in early 2021, the National Council of Radiation Protection and Measurements issued a statement about patient shielding. We'll look at it as well today. And the ASRT followed up very quickly in the days after that with 2 statements of our own. And then finally, today, we have the initiation of the Patient Shielding Task Force. And we'll talk a bit about the work that we are doing to help to educate our patients and our peers about this important change in clinical practice. So let's go back just for a second and think about that summer of 2019 following the AAPM statement. The board of directors at the time issued this statement. It's rather lengthy, so I'll magnify a portion of it here. We felt that we could not endorse the proposal to remove gonadal and fetal shielding initially because we felt that we needed to do some more research, review the science and the literature, and think about the ramifications about this important change in practice, everything from how technologists are shielding their patients routinely to how shielding is being taught in the classroom here in radiography programs, and also how shielding is legislated across our country at the state level, where actual state documents have specific guidelines for how patients should or should not be shielded. So this is obviously a very complex issue, and we thought it best to sort of take a measured approach, which is why we issued this statement again in the summer of 2019. What we were also awaiting was official recommendations from the National Council on Radiation Protection and Measurements. This is an organization here in the United States that reviews and implements recommendations, from the International Council on Radiation Protection and Measurements. And the NCRP here in the United States is really the leading authority on radiation protection. In early January of 2021, they issued this statement where they too recommended that gonadal shielding not be used routinely during abdominal and pelvic radiography. But notice the specific language here was specific only to those types of radiographic procedures, abdominal and pelvic. Very important consideration. The ASRT Board of Directors immediately jumped into action, and we issued our own statement on that same day. I know this is a little bit wordy, so we'll just highlight on that third paragraph there, and I'll expand it. Consistent with our commitment to a culture of radiation safety, it is the ASRT Board's position that it is appropriate to discontinue shielding for abdominal and pelvic imaging. The other key thing we mention here, though, is that that is the case only when the exam is performed by a registered radiologic technologist. As radiation health experts and individuals who are educationally prepared and clinically competent, we are the individuals best suited to implement this change in shielding practice, and we felt it was very important to highlight that fact as well. We followed up just a couple of days later just to drive home a second point. You can see that highlighted here in the middle paragraph. We wanted to make sure that everyone understands that our board supports the continued use of shielding during procedures where the placement of that shield is appropriate and safe, and where it's aligned with absolutely minimizing patient radiation exposure. We give a clinical example there of the placement of a lap shield during a radiographic extremity procedure, and we'll look at some images there in just a second. We felt that this can still be a best practice. So in summary, our position is that shielding remains an acceptable practice as long as it does not lead to a repeated image. Of course, that's something we all want to avoid as radiographers. We understand that improperly placed shielding, especially in the exposed field, can cover up or obscure anatomy. We want to avoid it as well. And we also understand that by placing a lead shield within the exposed field, when using automatic exposure control, this can cause the AEC to malfunction and actually inadvertently increase patient exposure, and we certainly want to avoid that clinical situation as well. So again, we agree that fetal and gonadal shielding should not be employed during abdominal pelvic radiography for these reasons. But there are other reasons and other indications where a shield can be safely implemented, and you see the image here on the screen as a good example. A young pediatric patient undergoing a lower extremity radiograph where the shield has been placed in a manner that is safe and effective and carries with it very little risk. When we talk about the benefit of the shielding, we really should look twofold there. This shield does reduce patient dose, albeit very minimally. In other words, the area of anatomy underneath the shield is already receiving a very low radiation dose. This shield only works to reduce that low amount to an even lower quantity. But there is an upside here, the psychological and emotional benefit of the shield, both for the patient and perhaps even for the caregiver, right? Imagine the patient's parents that are in the room here. They're certainly going to want to see that the radiographer is taking every step possible to maximize the safety of this patient, and the shield placement here certainly accomplishes that. Some other important considerations, building on the prior point. By properly using shields, we're making sure that we are maintaining the confidence and trust that patients have in our dedication to their safety. One of the reasons why the AAPM proposed the elimination of shielding was that the placement of a shield could possibly exacerbate or increase radiophobia, which is absolutely a real concern. Our position here is that we need to take a very proactive and deliberate approach to combating radiophobia. And eliminating the use of a shield one patient at a time in and of by itself may not be the best approach. We need to educate our technologists, our peers, and most importantly, our patients about the safety of our procedures. Simply eliminating the shield is not the best way to teach that our procedures are safe. We need to teach that first to make sure that both technologists and patients understand the rationale behind the elimination of shielding in some situations. Equally as important is the fact that we need to make sure our technologists understand the rationale here as well. What we've noticed anecdotally, based on observations and what's been reported to us, is the cessation of shielding has been expanded beyond what is appropriate. In other words, we have seen and heard reports of technologists no longer shielding themselves properly along the same line of logic that's been used to eliminate patient shielding. And that is completely inappropriate. We need to continue to employ all measures of radiation safety for occupational radiation workers. Radiologic technologists need to wear appropriate leaded apparel during fluoroscopic procedures and portable procedures and so forth. So we, again, want to make sure that technologists fully understand the rationale and the focus of this change in clinical practice to eliminate shielding only during a radiography of the abdomen and pelvis and only for patients. So looking forward ahead, what the ASRT has done in order to get this message out and to educate ourselves and our peers and our patients, we've put together this patient shielding task force. I have the privilege of chairing that task force, working alongside the current chair of the ASRT board, Dr. Christy Moore. And we have a number of members from all across the country with varied areas of expertise, working together to do a couple of things. We're looking to develop and disseminate a very clear and consistent message on the elimination of fetal and gonadal shielding during abdominal pelvic radiography. We're going to do so by designing and disseminating media and educational materials to educate ourselves and our peers, educators and students. We also want to, equally as importantly, to educate our public, those that we serve, our patients, to make sure they understand about the safety of our procedures and the rationale behind this change in shielding practice, so they're not surprised by it or curious about it or concerned that we aren't taking every step to ensure their safety. So we've done a couple of things already. We published a short article in the ASRT scanner earlier this summer. In just a couple of weeks, we have a short report being published in our scientific journal, Radiologic Technology. We're developing various educational materials as well. We are building a new section of the ASRT website dedicated just to shielding, and that's going to include some educational videos and animations that will be used to educate, again, not only technologists, but the public at large. And I have the privilege today of sharing one of those with you. This is a short video. It's about 2 minutes, and it's something that we've developed, hopefully that will be used to educate our patients about this change in practice. And I'll give you a couple minutes to look at it. I hope you enjoy it.
Notice during your exam today that the radiologic technologist, the professional who is performing your exam, may not place lead shielding on you. While you may have had lead shielding placed on you for imaging in the past, there is nothing to worry about. Professional societies, including the American Society of Radiologic Technologists, have worked with scientists to determine that lead shields should not be used in imaging if the shield could hide important details or interfere with the exam. Because lead shields block X-rays, anything covered by the shield can't be seen on radiographic images. Exams that focus on the pelvis and abdomen no longer need lead shields because the radiation risk is very low, and it is more important to see everything in this area. The imaging equipment we use today is much better than older equipment, and most of our exams are performed using a very low amount of radiation. Instead of shielding during all exams, radiologic technologists use other techniques to ensure that your exposure to radiation is kept to a minimum while still capturing high-quality images. For a few procedures, we still use shields to further reduce your exposure to radiation. Your best shield during imaging is the radiologic technologist, a highly trained professional who knows all the latest techniques for keeping you safe and reducing radiation dose while capturing high-quality images. Their skills, combined with modern technology, result in very safe and low-dose imaging procedures. If you have any questions, feel free to ask the radiologic technologist who is performing your exam today. We are here for your safety and to ensure you receive a quality exam. Don't worry, radiologic technologists have you covered.
So thank you for looking at that. Hopefully you heard the message that we hope rings true to this, that our main focus with patients is making sure that they understand that it is the skills of the radiologic technologist that is their best protection. In a sense, we embody the shield that protects them during their radiographic procedures. Our clinical expertise is their best protection. So hopefully that message rang true as you watched that video. So we could use your help. We have set up an email address to receive comments or questions or concerns from you all. We'd love to hear about shielding in your area, where you live, where you practice, what's going on, how things change. Do you have concerns about how they've changed? Do you have suggestions for us as we're developing new educational materials? We would love to hear from you. So please send us an email that comes directly to our task force, and we'll certainly use that information in our work moving forward. Again, shielding@asrt.org. Please contact us. Quickly, in conclusion, certainly the science behind radiation dose and risk is definitely changing. Our procedures are safer. And therefore, we definitely agree that we should not be routinely shielding the fetus and or gonads during abdominal pelvic radiography. But we do feel that shielding remains and can remain a best practice when it is appropriate, again, as part of our comprehensive approach to radiation protection. And most importantly, there is no change to occupational shielding. We need to be setting an example for our patients and for our healthcare colleagues in making sure that we are keeping ourselves safe from ionizing radiation. And of course, our ASRT Patient Shielding Task Force is here to help. I know change can be hard. This change has certainly had its challenges along the way, but one thing is for sure that our patients deserve the very best imaging service from us, from radiation health experts, experts that are taking every step to minimize risk for patients during our procedures. I want to thank you for your attention today. It's been my pleasure, and we hope to hear from you. Take care.
What a great session we have from our 4 speakers from all around the world. And I would like to have our consultant CEO, Dimitris Katsiforakis, to have a word.
Oh, thank you. Thank you, Napavon, dear chair, the president of the ISRRT, the dear speakers. I want to thank you deeply for your contribution in today's session, which discussed the various aspects of the very hot topic of patient shielding, which at some point comes around what we have been taught, instructed and practiced for many decades now. But as radiographers, by discussing and adapting the new scientific-based information, we are proving that radiographers and technologists are always at the forefront of the evidence-based practice, as was pointed out by our speakers. Once again, I deeply thank our speakers, and particularly our invited speaker from the International Society of Radiologists, Professor Donald Frass, for their contribution, valuable contribution indeed, to another successful ISRRT Facebook Live session. Thank you, Napapon.
Thank you, Dimitris. And now it's time for Q&A session. For the audience, you can type the question at the chat box on our Facebook Live session, and then I will just convey the message to our speakers. I have the first question for all the speakers here. The question is, how can we convince those, definitely the technologists, radiographers who has been practiced for years doing the shielding, and now we have pretty much a consensus from different parts of the world that we should end the shielding. How can you convince our colleague to follow the recommendation and the guideline? Let's start with Mark. Are you with us here?
Yes, I'm here, Napapong. Thanks very much for the question. Well, first of all, I would argue the assertion in the question that there is consensus here. I think that we can see from the ASRRT and their position on this that lead shielding remains a useful tool for radiographers in a professional context. I think that was very well put by our colleagues from the ASRRT today. And although today I presented on the practices and the beliefs of radiographers in Europe, UK, and Ireland, I have given previous presentations in which I have challenged some of the assertions in the evidence put forward against shielding. I do believe it remains a valuable tool. My main belief in this category is that radiographers should be left the opportunity to make an autonomous decision that best deals with the patient's needs and concerns at the bedside. And rather than talking about how we implement a guidance that says not to use it, I think we should be rolling that back and saying, especially in the language, that it remains a tool or an option to the radiologic technologist or the radiographer where the need arises. And that would be my response to the question, Napapong. Thank you.
All right, thank you, Mark. And now let's move to Dr. Frutch. You have any opinion on this?
Well, I do, and I think that the content for this course was excellent and laid the foundation just for a question like this. And we need to emphasize that the current recommendations are, again, don't prohibit shielding. It is just an opportunity and an option to review and revise the practice for which one uses shielding. And that, as we see, may be quite different in Hong Kong than it is in parts of Europe versus the United States, because there are cultural expectations, et cetera. And so I would offer that in addressing the question of how do you address the individual staff members' concern about this is to develop a practice policy, with the input of all of those relevant stakeholders. And that should include the radiologists, the radiographers, medical physicists, conceivably administrators, communication experts, patient advocates, and arrive at a policy which is harmonious with the sensibilities and the cultural expectations of that region, of that practice, so that it is not, this is not a global generic kind of recommendation that is seen as being, you need to reconfigure how you do things. So really that's where it arises from. It needs to be from the grassroots, but taking into account the current scientific evidence. So summarily, we no longer have to do this in all situations. I think that's the change. Previously, it was to a large extent, we are as a global community required to shield in situations where the examination is close to the shield, but also remote shields. That is no longer the situation. And as we've seen, there may be some situations in which to use this, but those have to be constructed based on the individual practice, the individual institution. It may be as broad as the individual region in terms of how best to do this. So it's not going to be one practice suits all.
Thank you, Dr. Frutch. And now let's move to Edward from Hong Kong. What's your opinion on this?
So, just I have said in the presentation, I agree with the other speakers. This is not the only one practice to remove the patient shielding. So, wise in Hong Kong, we still have the policy and also the regulations say we still have to use. But as a so-called, we have working for the professional organization, we are going to move to promote this kind of idea to the government, even the stakeholders, Hong Kong, even in China, say this kind of patient shielding can be considered, is it necessary anymore? And I think actually from the practicing radiographer, I think he welcome to this kind of policy because I say before, the workload in Hong Kong, even in China, is very high. So applying the very accurate patient shielding is not easy task for the so high frequency of the workload. So for the practicing side, I think they will welcome this. But I think the most important is how about the feeling of the relative, the patient. So on the other hand, we have to educate them, but it's not an easy task. So, for example, I can give you an example. When I work in China, the protective gear in China, they have some kind of quite, I think you may think it's a quite ridiculous policy. They have an expiry date for all the protective gear, 5 years. Every protective gear, they have to change every 5 years. So when I work in China, I have to make a lot of effort to say, no need to take away the protective gear. You should not have the expiry date of the protective gear. And we just have the good monitoring and good inspection system, so we can keep it using. So until 2020, they changed the policy. So they apply the monitoring system for the gear, so we can keep it. So I think in China, even in the Asia country, we take time to think about this, and we need time to educate the patient, especially the parents. For example, we also facing some kind of complaint about Mark have said that, maybe another speaker said that, the parents accompany with the children. They put on the protective gear. Why my kid cannot have it? So we have to explain it. For example, just really cover the pelvic region, we cannot use it. For example, on the other hand, for other cases, just like X-ray the extremity, so we give them some protective device for just easier about the patient concern. That's what I mean. And I think we have to take time to change. But this is, I think it's a good news for the practicing the front line. That's it.
Thank you, Edward. And now it's time for Daniel from ISRRT. What's your thought about this?
Thank you. I think the most important thing we can do moving forward is to make sure there is a consistent message about this topic amongst all the important professional societies and other organizations. To speak to Professor McEntee's point about there being a lack of consensus, I think that comes from some early inconsistency in the messaging. I think the NCRP here in the US hit it right when they were very specific about the elimination of fetal and gonadal shielding during abdominal pelvic radiography. What we've seen is that message has gotten lost somewhere along the way and has expanded to a point where all shielding is thought to be banned. As Dr. Frush mentioned, that is inaccurate and inappropriate. So I think we need to take a step back amongst organizations and making sure we're communicating with each other, first and foremost, that our messaging is consistent so that we can start to eliminate some of the lack of clarity and frankly, some of the confusion that's out there. The ASRT is taking steps to do that with our shielding task force. And, we would love to work with other organizations as well to partner on our efforts moving forward to make sure that that message is consistent. And I think that's the best thing we can do to make sure that it is implemented appropriately. Thank you.
Well, thank you, Daniel. I think all of the speakers today cover what we really expect, but to give a message, the final message to all radiographers who view us right now at the moment and who will come back to take a look at what we're going to record today. What kind of message you want to tell us as radiographers in terms of the shielding in our radiography practice? So I would like to have Mark as the first person. What do you want to tell us about this?
Yeah, look, I think an important thing is that we remain a scientific organization. That we will change our opinions based on evidence. We are evidence-based practitioners, but I do not think that the messaging has been very clear here. And as Daniel said, a lot of people have taken the message that you don't need to shield at all, and that's incorrect. I believe strongly radiographers should maintain shielding as one of the tools, and maybe not the most important one. We absolutely, that is absolutely true. It's a small amount of dose, but it is a dose reduction. It's one of the tools that they can use, and I think as long as they're not causing extra repeats or not causing extra dose, I would say, don't shield in the field of view. Don't place a lead shield in the field of view. When the lead shield is outside of the field of view, then it's safe to place that practice. And that is a change in practice. And I think we should do that in line with the evidence base. But we should not remove shielding as an option completely. And unfortunately, some people have taken this as an opportunity to change practice and actually remove shields from the department completely. And I'd be worried where Edward was saying there, that the practitioners would be happy because it makes it faster. That is not the reason why we should change. We should continue to provide the best protection for patients possible. And we shouldn't change just because it makes the examination more efficient not to shield. We should remove shielding where it is a risk and keep it where it provides sometimes protection for the patients and sometimes some enhancement of their care. That would be my message. Thanks.
Thank you, Mark. And now it's time for Dr. Fresh. What do you want to tell us radiographers about this?
Well, I guess I'd like to take the perspective of the radiographers and those individuals, particularly who were presenters on this case, are such a strong voice in this this whole effort. The radiographers really are front line and should continue to have an incredibly strong voice as policies and guidelines are developed. And so I would say take the lead, look at your individual practice, take the science and the evidence to heart and see what is going to be in the best interest of your individual practice and the patients that you deal with and delivering a good quality health care. I would also offer that working together with the entire imaging team in developing talking points and answers to those questions which are going to come up from the public and from the patients and caregivers, say for children, is a really important thing to do. So these are what I would advise, and continue to just have the strongest lead in pushing this whole effort ahead, and to be, again, consistent with what you feel your individual practice needs are.
Thank you, Dr. Fresh. And now it's time for Edward Chan. What's your thought?
Yes, I agree with Mark. Talk about your high workload doesn't mean you have to take away the shooting. So while most of the stakeholders in Hong Kong still asking our radiographers to do the good protection. So from my point of view, I will still asking my radiographers have a good practice of applying the phone shielding. They should have the technique. Just as I mentioned in my presentation, they should have the technique. But just like the case, if doing the pelvic region or the gonadal region X-ray, we should not use that anymore, except very special occasion we really need to apply. But I still, for the training, I still asking the school or maybe in the department, we train our radiographers to know how to apply the proper radiation protection for the patient. So as a manager, also as a certain kind of stakeholder in the field, I think still we need the radiographers to know that they have the technique and they should do it if necessary. Just what I mentioned, the parents still, or even the patient themselves, sometimes we're really anxious about the radiation, certain extent, even until we have very good education about how the radiation has to them. That's it.
Well, thank you, Edward. And what you talk about China is very excited. Like what they're doing is very eye-opening.
Yes, I can say in China, you want the public to trust so-called professional. It's not an easy task.
All right, that's our job. And now it's time for you, Daniel.
I think the message that I would like to send out to our colleagues is this. The scientific basis behind the elimination of gonadal shielding during abdominal pelvic radiography is sound, is appropriate. And it's based on the overall safety of our procedures. But the most important message that I'd like to reinforce is that safety, the safety of our procedures, is not a given. It's predicated on our expertise, on our implementation of best practices, of being radiation health experts. We, as radiographers, are the patient's best protection. We, in a sense, embody the shield that is going to keep our patients well protected during these procedures. We need to stay well informed. We need to participate in webinars such as today. We need to read the latest literature and be the radiation experts that our profession and that our patients need us to be. And I think that's the most important message that I want to reinforce. It's all up to us. Thank you all again.
Daniel. Thank you. And now it's time for you, Donna, to have a closing speech.
Yeah, I actually want to thank our lead experts from around the world that have just shared with us best practices and current practice that are happening in their regions and countries around the world. I think that we have just demonstrated the complication of when a message is rolled out and how it can go sideways and implement things that we didn't intend to be implemented. And I appreciate this expertise. And I really, truly appreciate Dr. Frush and the International Society of Radiology, Quality and Safety Alliance, because as key stakeholders in the global profession, we believe that we have to take a team approach. We have to work together to get the right messages out there and to get the information to areas of the world that don't have the resources that some of our developed countries have, so that we can begin to continue to protect the patient, which is our most important aspect of our job, and give the same message around the world. So I thank you all for sharing with us. We will continue to work together with our global stakeholders to provide opportunities for us to share these best practices and to bring forward the right important information to our members around the world. And know the ISRRT supports its member societies and will work together in a team approach with our global stakeholders. And I will turn it back over to Dr. Frush to have the last closing word.
It's really tough to follow those closing words and the comments. I always learn so much from these kinds of situations here. I think this was a really important topic. I am so pleased to have the ISRR join ISRRT in this. I think we saw some very interesting material. There's still a huge need for clarification here on what the practice should be. The voices from the individual communities represented by the speakers are so very important. And I look forward to working together. That is collaborative efforts from the radiologists, from the radiographers, and from medical physicists to help in improving what we do for patient care. And the shielding is such a good illustration of that kind of need for stakeholder effort. So my congratulations on the panelists at an excellent session. It was really a privilege to be involved with the other speakers. And I hope we can do this again and follow up maybe in 6 months. I think it would really be clarifying. And thanks to all of you who could join today.
And thank you, Dr. Frush, and all the speakers for today. And I think that concludes our program here today. And I hope all the audience have a good day. Thank you and goodbye.
Bye-bye.